Hola, buenas tardes. Soy Javier de Castro, oncólogo médico del Hospital La Paz. En primer lugar, quería agradecer a la Fundación ECO su amable invitación a esta jornada maratoniana y muy interesante sobre inmunoterapia en cáncer de pulmón. Tengo el placer de compartir esta moderación con la doctora García Campelo, donde vamos a hablar de tres temas fundamentales, como son los largos supervivientes, las resistencias y cómo secuenciar los pacientes con inmunoterapia. Sin más preámbulos, por intentar ajustarnos al tiempo, paso la palabra a la doctora García Campelo para la primera presentación.
Buenas tardes, gracias a todos por estar ahí, gracias por estar al otro lado de la pantalla y sin duda un placer compartir esta mesa con mi amigo y compañero Javier de Castro y con excelentes ponentes que yo creo que nos van a ilustrar fantásticamente una situación de situaciones del momento actual que estamos.
Current situation in the field of immunotherapy. Without further ado, it is a pleasure to introduce Enrique Carceneri, medical oncologist in Barcelona, and he's the vice chair of colon cancer group. Enrique, you are dealing with one of the trending topics, the long survivors in lung cancer. You have the floor, Enrique. I'd like to thank once again the organizers of the scientific committee of this session for their kind invitation. And without further ado, we are going to talk about the long survivors.
De acuerdo.
Vamos a hablar de largos supervivientes en cáncer de pulmón.
Going to talk about the long survivors in lung cancer. These are my disclosures. Talking about long survivors reminds me of that art years ago, what do the clouds smell like? It is a concept that we started to develop, but I'm not sure if we truly know what we're talking about. I would like to start with a case in our office, a 73-year-old man with a squamous cell carcinoma, stage 3. And in July 2012, he started a first line of treatment with carbon-flatting cell. In July 2013, he progressed, and we started a second line with docetaxel. After a few months and certain stabilization, the patient progressed again, July 2013. That's precisely when in the treatment he was immersed in a clinical trial. He was immersed in the study, and he studied from until now. When we take a look at this case, we clearly know that this is a long survivor, but we clearly know what this is. Do we really know what this is? We talk about long survivors of lung cancer now, or not in the past. When we had the onset of the anti-target treatments, we had some long survivors, but very few. And obviously, with chemotherapy, talking about long survivors was unthinkable. It was very odd, and we thought if the patient was living for a long time, there was probably a diagnosis problem. More than 2 years, it was very difficult. Now we are starting to see this process. The patients that have managed to secure long periods of remittance of their disease, even when we discontinue the treatment. And this is what we are talking about, long-term survivors. To me, the most important, takeaway from this presentation. Okay, let's try and define how can we define a long-term survivor, because we all know what it is. But when I said, okay, we find it difficult to find a definition, it is a case. We'll introduce the numbers of patients who become long-term survivors with what treatments, and how can we select which patients can reach this situation. But by looking at the bibliography and the existing literature, we have seen that a long-term NSCLC survivor is those who lived for more than 5 years, This definition, the classical definition, and rather old, is still valid. A patient living for 5 years with an advanced long-term cancer, it'd be a long-term survivor. If we need to wait for 5 years to understand they are a long-term survivor, all processes in this situation, well, we won't be able to assess it before these 5 years. By studying the bibliography and the existing literature, papers say that an LTS patient is somebody who survives from diagnosis of 2 years, and the other one is too rigid, perhaps, or we need a lot of time to define such population. And this perhaps is very loose. And I believe at the moment, even without immunotherapy treatments, we have a lot of patients that already with chemotherapy could live for 2 years. So to me, the definitions are short-sighted. We need to do an effort now from the scientific groups, the different associations, in order to try and come up with a common definition. What does it mean to become a long-term survivor? Recently, a paper has been published, presented last year, and to me, this is the way I like to present these things, what a long-term survivor can be. It was presented last year in the Meyer, an analysis of the 2-line studies of volumab, where they show that those patients that do have a free a PFS of more than 2 years have a 60% probability of being PFS after 5 years, and PFS after 5 years of 80%. If we increase it to 3 years or 4 years, this PFS increases. So in my opinion, I think this is a good definition, defining as a long-term survivor, long-term cancer, those patients that reach 2 years of survival PFS, because we expect these patients to have an 80% probabilities of becoming or being alive after 5 years. Which information do we have of long-term survivors? The main information is the information that we receive from the stage 1 or phase 1 studies, because they have the biggest follow-up here. The first one that we are going to present, the phase 1 nivolumab study, that is testing different doses, including 35 patients with long-term lung cancer. And 40% of the patients, 14 or 15% of the patients are LTS after 5 years. The other study in phase 1 with Pembro also analyzes survival after 5 years. And also we've realized that the previously treated patients have an overall survival of 15%. And for those patients, the group of patients who was naive for the treatment, these increases a little bit up to 23%. We may argue that with immunotherapy alone, almost 15% of patients may be having a global overall survival of 5 years or more. We also have information of second-line studies, like the ones we mentioned, the combined second-line treatment, nivolumab, which combines the C17 study for non-squamous and squamous versions. We have seen the data presented, and the 5-year survival is 13 or 14% for second-line treatment patients. We also have information on second-line of atezolizumab. This is the Poplar and Oak study, phase 2 and phase 3, including patients that had progressed in 1 or 2 lines of treatment, including patients with a histology of a squamous cancer and non-squamous cancer. And in both studies, we have found a 4-year survival of around 15%. Pembro, second line, It included also patients in third line, but the keynote study for this population of patients who progress with a platinum-based treatment, the 4-year OS is around 23%, with differences in the expression of PDL1. Remember that in other studies they were only including PDL positive above 1%. And the first data that we have received for the Keynote 024 study for such population of patients with lung cancer naive with an expression of PDL1 above 50% that are randomized to Pembro or the platinum doublet. The 5-year survival here is around 40% for the group of patients that I choose IO, and we do not have follow-up data for the chemo plus IO, but we start receiving data from the Empire 150 study with a 3-year follow-up. 20% of patients are patients who are alive in this situation, and for the non-squamous study with chemo and Pembro, we've got 2-year progression, and 45% of patients are still alive. And the most interesting thing, the OS is interesting, but the PFS is also interesting. We'll follow up this information. There is up to 22% of patients of PFS after 2 years, that probably these patients have a higher probability of almost more than 80% to be alive after 5 years. What happens with the other first line treatment, Checkmate 227? We also have information from this study, global overall survival after 3 years, which is divided between nivolumab and pilanumab, and the combination of nivolumab and pilanumab is up to 30% of patients alive. As you see, there are barely no differences for the expression of PDL1. Such information can be interesting because perhaps the combination of both immunotherapies may reach longer survivors in patients with low PDL1 expression. We'll have to see the combination of several immunotherapies if they manage to increase this ceiling of long-term survivors. What happens with the other group of patients with long-term cancer, the small lung cancer? We do not have sufficient monitoring. We do not know if we will have long-term survivors in the numbers we have seen, as it was the case in patients suffering from an NSCLC, but we still start having overall survival data. The Caspian study, 23% after 2 years still alive versus the control group of 14%. And after 18 months for the Empower 133 with atezolizumab plus chemotherapy, 34% versus 21% are alive after 28 months. We require additional follow-up in order to see how many patients reach 5-year survival. How can we select the patients? What are the features of these patients? From the combined analysis of the second-line studies, in both groups, nivolumab and docetaxel, the general state PS0 was a prognostic factor or predictive factor with more than 5-year survival, and only for nivolumab, above 1% expression predicted a higher probability of becoming a long-term survival. Apart from PDL1, predicting the answer can also allow helping those patients with longer survival rates. This shows what happened with the patients in both studies. Of those who survived 5 years, 21% progressed. Sorry, 21 patients, as the speaker. They received all the therapies, 19 patients, 12 with other therapy and the rest with immunotherapy. 5 discontinued nivolumab and 16 continued with something else. And as I mentioned already, the PD-L1 could predict those patients with a higher probability of becoming long-term survivors of long-term cancer. It is interesting in this checkmate 227, there is a benefit for those patients with a PD-L1 below 1%, and in this combination, it seems that the PD-L1 is not so much a predictor of the long-term survival as it is with other cases. It is important to mention in this analysis of checkmate that patients with a very high expression above 50% to have a higher probability of these Keynote 001, higher probability of becoming long-term survivals of almost 30% after 5 years for naive patients versus 15% of patients with an expression of 1 to 41. And for those previously treated or with an expression above 50%, 25% of the patients have a survival after 5 years versus patients without PD-L1 expression, which is only 3%. So in this study, and if we measure it with another technique, another way of measuring this, these are the atezolizumab and the second-line studies. They've also seen that those patients, if we see it differently, those patients with a high expression have a higher probability of becoming long-term survivals, 30% after 4 years for the Poplar study, and almost 30% for the expression data, whereas this proportion for negative patients goes down to 14 or 15%. It is also very interesting to note that these patients which continue with the treatment of immunotherapy present very few IAEs after 3 years. They continue with the treatment, and it is quite safe, and it could be somehow related. The long-term survivors of long-term cancer, the response rate can also be related. Because of the checkmate 227, we know that those patients that have reached 6 months response, either complete or partial response with a high PD-L1 or low, have a higher probability of being alive after 4 years, around 70% or 80%, versus 34% or 40% for those patients who did not respond. Of the pembrolizumab studies, the Keynote 024, or those patients, we know that those patients that have done 2 years of treatment and have a higher probability of becoming long-term survivors or being alive after 5 years, those reaching 35 cycles, there is a higher proportion of patients that have an adequate response. In the Keynote 24, the response, the overall response rate of patients after 2 years was 82%. In the Keynote 189, it was 85%. This is information presented in ASCO this year. And as far as the clinical features of the patients are concerned, please note that those patients that have reached 2 years of treatment, there is a lower proportion than expected of patients with squamous carcinoma. And it seems that the histology may have a role. It seems that the squamous histology has less probability to have a long-term survival rate. In Pembro studies, this is clearly shown, but also in the second line atezolizumab treatment is also clear. Those patients with squamous histology have an only 7% overall survival after 4 years versus 19% of the patients with the non-squamous histology. So the histology may be a relevant factor. And please take into consideration the confusion factor. The comorbidities of patients or patients with squamous histology may probably have comorbidities associated to tobacco consumption, and this may be some of the conclusions. And with regards to small cell lung cancer, there is very little follow-up this year, but in ESMO we have seen these impacts on the IMPA 133 LTS combining etoposide carboplatin. They divide those patients, the long-term survivors and those who survive more than 18 months, plus the non-LTS that have a survival below 18 months. So the conclusions in the univariate and multivariate analysis, the DLH and the general state have an impact on survival. We will have to continue its follow-up in order to confirm whether these features or these parameters continue afterwards. And with this, I would like to finish here by saying that for long-term survivors, we need an effort to better define which patients can become long-term survivors, because we cannot wait for 5 years to take decisions in patients with immunotherapy. With the existing data on patients and the PFS, we need to consider that they are long-term survivors, and this has its clinical implications. The current situation we are living, deciding if they are an ICU patient or not in a long-term cancer is very relevant. So 15% of the patients may end up becoming long-term lung cancer survivors. We need to wait for the first-line treatment studies in order to see if they have reached better results for long-term survivors. And although there are factors that may probably define a greater probability to become a long-term survivors with a high PD-L1 expression and non-squamous histology or response to the treatment, we cannot rule out any possibility for patients to become long-term survivors. Thank you very much, Enrique. Thank you very much for the kind presentation. And I'm sure you have introduced very interesting topics. And I would like to introduce now Jordi Elemon, who's well known by absolutely everyone. This is one of the references in Spanish oncology in identifying a more personalized medicine and a more fruitful approach for treatment of this kind of patients. Jordi, you have the floor. He currently works for Delphos Clinic in Barcelona, but he's a prominent keynote speaker and a researcher in the field of lung cancer. Whenever you want, you have the floor. Thank you very much, the Castro and Garcia Campello. I would like to thank the scientific committee for this kind invitation. And obviously, let me just present what I'm going to do over the next few minutes in order to see if I can shed some light in this very shadowy moment. What is it that we can do with metastatic lung-term cancer that progress in the first line of IO? Dr. Casarin said it before, IO has completely changed the paradigm of oncological patients, but what's true is that the number of drugs being incorporated in the therapeutic strategy in long-term lung cancer patients is increasing. And recently, 2 new anti-PD-L1 one have been introduced. They have introduced efficiency in monotherapy or in combination with chemotherapy in advanced stage lung cancer. The treatment paradigm has changed again with a customized therapy. And today we have long-term survivors, around 20 to 30% of patients survive after 5 years with IA treatment, and this will depend on the line of treatment and also the PD-L1 expression. Despite this so promising information that has been presented, we must argue that not all patients today respond to immunotherapy treatment, and we know that in the best possible scenario, 50% or less of the patients with lung cancer will respond to the first line of immunotherapy, and there may be a reverse correlation between the responses to immunotherapy and the risk to develop acquired resistance, although this is very heterogeneous in different tumors. Patients progress, and we need to know what to do with the progression. It is very important to establish different definitions about resistance. And recently, a group of experts has defined in a broader consensus that the primary resistance is for those patients that receive an immunotherapy treatment for at least 6 weeks that do present a clinical improvement and a progression before 6 months have gone by. Whereas the acquired resistance are those patients that progress after 6 months. Both primary resistance and the acquired resistance is linked to intrinsic aspects, but also to extrinsic aspects. In such definition, we may argue if the 6-month cutoff is a realistic one, or perhaps it's got to be a 4-month cutoff. And we must not forget that there is a percentage of patients that do present a new pattern of resistance, which is going to be mentioned hyperexpression of the disease when they receive the immunotherapy treatment. But it isn't easy to research on this resistance. It is not like when we try and find out the mechanisms of resistance with oncogenic addiction, because these mechanisms will only depend upon the oncogenic way of the tumoral cell, regardless of the variability of these resistance mechanisms. And it is much more complex for those patients receiving immunotherapy, because these will depend on the tumor, the cancer cell, the host, the environment, the microenvironment. These can reduce the immunotherapy treatment. And today we are not used to, or perhaps we do not have the input in our practice to try and carry out biopsies to these patients in order to understand what are the resistance mechanisms. Within such complexity, that needs to be taken into consideration. In a lung cancer, we may have different types of primary resistances in the treatment of immunotherapy. Lung cancer immunotherapy is not only a monotherapy, but also in combination with other therapies, and even with other administrations. And the differences in administration can trigger different resistance mechanisms. As I mentioned already, within the intrinsic mechanisms of resistance of the cancer cell, either it's acquired or not, has to do with the general capacity of the tumor. Because we do not have neoantigens, we do not have the capacity to trigger the immune system, or perhaps because there are different pathways that can be altered, and there is as such an increase of the angiogenesis and a general state of immunosuppression. There are extrinsic mechanisms that depend on the tumoral cancer environment that can be subdivided into 4 leading groups: a lack of or ineffective presentation of tumor antigens to the immune system. If we do not have these cells that stimulate the immune system, we will always have a primary resistance. This can also be extrinsic because oftentimes in the T cell there is immunosuppression, or because within this cancer environment we have cells with capacity of immunosuppression, myeloid related. And the fourth mechanism of this extrinsic capacity is because the tumor can expel certain quercetins or other agents that provoke a shield in the tumor, and therefore the immune system cannot act.
Claramente escasa, y lo que conocemos a nivel clínico es a partir de un reporte de 13 reportes que incluyeron 58 pacientes.
What we know at clinical level is from different reports, including different patients treated with immunotherapy. So the mechanisms are heterogeneous, and mechanisms that are valid for one tumor sometimes cannot be applied to other tumors. For example, the mutation of B7-H3, but it's a resistance mechanism, but it's not shared. Actually, Hodgkin lymphoma are the tumors with the highest response rates, 90% of patients, but 70% of Hodgkin lymphomas has a mutation of beta-2, and they continue to respond to immunotherapy. So we cannot think that all the resistance mechanisms are shared by all tumors that are going to receive immunotherapy. Very often, therapy approaches we use to revert these resistance mechanisms have been completely empiric after simplifying as much as we could these mechanisms. Of course, there are many clinical trials, ongoing clinical trials, in which they're trying to research about different combinations to try to reverse or reduce the percentage of patients that could have a primary resistance. As a matter of fact, the first step to reduce this resistance was adding to immunotherapy chemotherapy. This way, we increase the responses and particularly the PFS. But I think that one of the most important points that has helped to improve this chemotherapy was avoiding hyperprogressive disease. This retrospective study was recently presented, led by Dr. Ferrara. Even patients treated with immunotherapy in monotherapy with high expression of PD-1, 16% of these patients can have hyperprogressive disease after immunotherapy. It can reduce to 6% when they receive a combination of chemo plus immuno. Avoiding primary resistance is very important, but the problem we have right now is what do we do with patients that have progressed with immunotherapy, acquired resistance, so to speak, after receiving the treatment. One of the first steps taken was combining anti-PD-1 or anti-PD-1 drugs with antibody-stimulating T cells, or with antibodies that block the inhibiting capacity of T cell. But many drugs have been tested, and my conclusion is that none of these combinations in patients with lung cancer, immunorefractory lung cancer, have shown an evidence of a clinical benefit, which is enough to be applied in our clinical practice. One of the most recent examples was anti-TIGIT drugs. We know that TIGIT is a protein expressed in T cells and NK cells, and it has an immunosuppressive function. We know that in first line, in naive patients with high expression of PD-1, the combination of anti-TIGIT drug and atezolizumab has a synergic effect. But with this, when this strategy is applied to patients that have progressed with immunotherapy, we know that anti-TIGIT monotherapy or anti-TIGIT with pembro does not provide a benefit of responses below 10%. Therefore, these combinations of different antibodies do not appear to be the best ways to try to reverse this immunoresistance. Other strategy tested was a combination of immunotherapy with small molecules. I think this is important. This is from COSMIC study. They assessed 29 patients with advanced lung cancer that progressed with a previous therapy of immunotherapy. Cabozantinib and atezolizumab. Cabozantinib is a small molecule with androgenic functions, immunomodulating functions through the modification of macrophages. This combination has achieved 20 responses of 27% with PFS 4 months. These data are promising, but although there's a toxicity of 47%, specifically as Stenia has launched a phase 3 of a study that compares cabozantinib and atezolizumab with docetaxel. It's a very interesting study. but it's not optimal or unethical because the second line of treatment should be docetaxel with an antiogenic drug, because we know that angiogenesis way is an important way of resistance mechanisms to immunotherapy, so it would have been better to have docetaxel with an antiogenic drug. Within this strategy of combining immunotherapy with small molecules, we have this other drug, sitravatinib. It's complicated to pronounce. It's also a small molecule with anti-angiogenic and immunomodulating function. And in phase 2 study, it showed that in 73 patients that were immunorefractory, responses were almost 30%, and survival, I think this is very relevant, 18 months. This important data caused a phase 3 study that compares nivolumab with sitranib compared to docetaxel in lung cancer patients. So apparently the combination of immunotherapy with small molecules is also a strategy which has a 30% of responses, PFS of 4 months, and perhaps a survival of a year and a half. I think it's also very important and very intelligent, what I call intelligent antibodies. They're targeted against a specific protein expressed in the tumor cell, and they are a cytostatic drug. In ASCO, this drug was presented, SAR. It's against SECAM, which is only expressed in lung cancer patients. In this study, patients with lung cancer with a high expression of SECAM previously treated with immunotherapy, this drug achieved responses of 20% with a minimum duration of 6 months. And this promising data caused the launch of a phase 3 study, Carmen, that compares this drug with docetaxel in patients with high expression of SECAM and progression after immunotherapy. So I think that another intelligent strategy we should not forget about. I think there's something else which is also interesting, bispecific drugs. Part of the antibody binds with the protein expressed by the cancer cell. Other part of the antibody binds with a protein expressed by the T cell. They join them, and the immune system can attack the tumor, although there's no microenvironment which is favorable to immunogenicity. This has been tested with colon cancer patients with certain evidence of efficacy, but there's still clinical trials pending to be published for lung cancer patients. It's interesting for immune desert cancers. How do we act within the tumor microenvironment? I previously mentioned adenosine. This is generated by the tumor to create some sort of protective shield and to be protected by adenosine. We could act blocking adenosine, the enzyme that produces adenosine, which is CD73, or blocking the T cell receptor that has a receptor of adenosine. There's an initial study, a combination of adeso plus a drug, which is an adenosine receptor inhibitor, which has been proven efficient in immunorefractory lung cancer patients, regardless of PD-L1 expressions. So this is an important point to try to reverse resistance to previous immunotherapy. Another drug, canakinumab, it was developed to try to reduce mortality after heart attacks, and it was seen that it also reduced the incidence of lung cancer. It works with interleukin-1b. If we do that, we block the immunosuppressive effector and anti-angiogenic this interleukin has. This is a study that compares this drug with docetaxel in patients previously treated with immunotherapy. And another world that opens is the world of vaccines. We don't know what's the role of vaccines in patients that have progressed with a previous immunotherapy. And this year, the ESMO conference showed the results of this study, phase 3 study that compared patients with lung cancer previously treated with chemotherapy and immunotherapy, the efficacy of Tedopi, which is a vaccine made up by 9 epitopes. Epitopes are targeted at 5 antigens expressed in lung cancer cells in HLA-positive patients. It compared this drug with docetaxel. Although these differences in survival are not statistically significant, we have to say that this study was stopped due to the COVID situation. Inclusions have been stopped, but apparently the vaccine could play a role and there's a benefit in survival. And I think it's going to be very interesting to see whether patients that are generating immunogenic capability thanks to the vaccine are clearly patients that could be long survivors. Therefore, I think that vaccines could play an important role in this patient population. Another area, but I won't get into detail, the role of intra-tumoral immunotherapy in patients, progressing patients, to try to increase immunogenicity. There's evidence of this strategy in patients with naive melanoma, but what would happen in progressing lung cancer patients? I think this is very important, and of course, TILs. We have less experience than in melanoma patients, but this year a first study was presented with patients that were immunorefractory to nivolumab. Apparently, they can create a new response when this therapy is administered. I think that as of today, although all this data are very interesting, the only thing we're doing is increasing the number of clinical trials that we are carrying out. We cannot continue to carry out clinical trials without predictive factors. And I think the only thing we can do with the situation is doing many things without sense and without establishing the best strategy when a patient progresses. Today, we know that we can biopsy our lung cancer patients that have been treated with targeted therapy or immunotherapy. This has been established in a mature study. We know that reference mechanisms can be gotten when we rebiopsy these patients. There are patients that were treated with immunotherapy, and this biopsy was carried out. There are other interesting projects. This is a consortium of French centers, Project Pioneer. Lung cancer patients treated with immunotherapy, after 6 weeks, new biopsy. What's the aim of this? Trying to establish an immunogram based on 400 biomarkers, and at a later stage, establishing the personalized therapy based on the resistant mechanisms. And as a matter of fact, there's a Hudson study with the same philosophy. Patients with metastatic lung cancer that progress, new biopsy with next generation sequencing, they receive durvalumab with a targeted therapy based on whether they have 4 of the ways that have been established as resistance mechanisms to be treated with a personalized therapy. So I think we need to try to learn what happens with these patients, and we should not forget that a tissue biopsy can provide us with information, but also liquid biopsy is critical to learn about the efficacy and the resistance mechanisms in patients that are receiving immunotherapy. This part is very interesting, but we don't all have the possibility of taking part in clinical trials when there's a progression. What can we do in our daily practice? We know that RECIST criteria are not always the best criteria to define a patient's progression. There are different patient cohorts that have shown that therapy beyond progression could have benefits, even though they're limited. We know that patients to which we administer immunotherapy, chemotherapy based on double platinum has certain efficiency. What we don't know today, and perhaps it would be useful to make the difference, is whether if the patient progresses after immunotherapy, shall I switch to chemotherapy or shall I change to immunotherapy plus chemotherapy? Perhaps the Insignia trial could help us to have more information about the best strategy after progression for patients who progress with just immunotherapy. What I was saying that docetaxel and angiogenic drugs were so important in the studies, because there are different cohorts in which the combination of docetaxel with nitronib or ramucirumab after chemo and radiotherapy, whether there is sequential or concomitant, can have responses of 50%, PFS of over 6 months, and overall survival of over a year. So I think we cannot provide an clinical trial. in a clinical trial, we need to provide the combination of docetaxel and an angiogenic drug. We know that PD-L1 expression at baseline is different, and this expression can change through time after therapy. But we also know the tumor mutational burden is also heterogeneous within the tumor. This variability, these predictive factors could make us see a different response to therapy. And we know there are patients that can have a legal progression, and this could be treated with a radical therapy, surgery, and radiotherapy, for example, and continuing with the same drug and have a positive efficacy for these patients. And of course, as Dr. Casarin was saying, some patients at the end of the therapy, these patients clearly benefit from retreatment. Therapy evidence is very low, just 27 patients, but we know that retreatment is positive in 85% of the patients. The maximum benefit is for patients that progress after a year after the last dose of immunotherapy. But as Dr. Kanser was saying, as of today, we do not know the clinical factors, the biological factors that could tell us which patients could benefit from this retreatment. And I think this is very interesting. They're trying to validate the role of retreatment in lung cancer patients. As conclusions, I think we should take a step forward. We should try to get more information about the immunophenotype of our patients to establish the best initial strategy to avoid primary resistance. I think that all strategies that are blind are interesting, but if we want to move forward and have a personalized therapy for our patients treated that have progressed, it's really important to have a biopsy or liquid biopsy, establish the resistance mechanisms and see what the best options for treatment are. And no one should feel bad if you cannot apply all these clinical trials, but because what we're doing in our daily practice is already giving benefits to these patients. Thank you very much. Thank you very much, Jordi. It was excellent, as always. You've given us many challenges for the future. And now I'm pleased, although she doesn't need an introduction, I'm pleased to introduce Dr. Garasino. She's a friend. She's a great professional in oncology. She's a prestigious professional. We're delighted to have you with us, Marina. So you're going to speak about sequences, right? ¿Me podéis oír? Muchas gracias por invitarme. Siempre es un placer y estoy muy contenta de veros porque creo que España, pero también mi ciudad, está en una situación increíble estos días, así que es un placer estar aquí hoy. Desafortunadamente, vais a escuchar muchas cosas que ya se han dicho antes. Cuando me disteis este título, mi pregunta era, ¿hay alguna secuenciación óptima del tratamiento hoy en día? La pregunta real es, ¿podemos retirar la inmunoterapia de la primera línea en no microcítico? ¿Estos microcíticos de interés? Lo que sabemos es que la situación en 2020 es esta. Puedes empezar con inmunoterapia sola, con inmunoterapia, con quimioterapia, y puedes empezar con inmunoterapia e inmunoterapia. No estoy segura de si hay espacio para la inmunoterapia en segunda línea, pero es un buen punto que podemos debatir quizá más tarde. Por esto empezamos con el estudio PDL1. Sabemos mucho sobre esto, pero sabemos mucho también, como Jordi ha dicho muy bien antes, que tenemos múltiples señales que están coestimulando y coinhibiendo a los linfocitos T. Entonces, quizá la siguiente pregunta, como ha dicho Jordi, es ¿qué añadir a la inmunoterapia en la primera línea para superar la resistencia primaria? El segundo punto es que sabemos muy bien, ahora conocemos muy bien los inhibidores, los checkpoint inmunitarios. Sabemos que los neoantígenos pueden desempeñar un papel en el estudio de la carga mutacional tumoral. Es un papel para el agente único y menos para quimioterapia e inmunoterapia, pero creo que la otra parte, como también ha dicho Jordi, tiene que ver con el microambiente del tumor. Creo que todavía estamos en una situación en la que la biología del carcinoma de pulmón no microcítico todavía no se conoce bien. Entonces es difícil crear una secuencia racional en 2020. La otra parte es que, como sabemos, y a mí me encanta esta imagen porque parece una ciudad india, sabemos que hay múltiples células detrás del microambiente del tumor. Entonces, quizá dirigirnos a una de ellas, que es lo que estamos haciendo ahora, no es suficiente por la complejidad del microambiente, que es muy alta. Y quizá es difícil dirigirse solo a una. Y otra cosa que está apareciendo en los últimos años es la heterogeneidad espacial que puede desempeñar un papel. Podemos tener un linfocito cerca de un macrófago con un fenotipo distinto para tenerlo a una distancia distinta. Entonces, como dijo Jordi Ramón antes, es muy difícil predecir una secuencia racional en 2020. Y el otro punto es que tenemos muchos datos de PS0 y PS1 y tenemos datos de PS2. Y también sabemos que PS2 en general se asocia con un microambiente más inmunosupresor. Pero lo que tenemos es lo que tenemos y tenemos que tomar decisiones basadas en los ensayos clínicos y lo que ha dicho Eric al principio, la posibilidad de encontrar a los largos supervivientes basándonos en la clínica. Solo quiero volver al Keynote 024 porque creo que tenemos una supervivencia general actualizada para Keynote 24. El 70% de los pacientes no responden a la inmunoterapia, aunque tienen una expresión de PD1 superior al 50%. Estoy contenta con que el 32% de ellos estén respondiendo y sean largos supervivientes, pero simplemente quiero decir que el estudio es muy largo y tenemos que encontrar nuevas estrategias y más biomarcadores. El otro punto, lo siento porque mis diapositivas, vale, sí. El otro punto que es muy importante es que no estamos dirigiéndonos a PDL1 como la translocación y otras cosas. Tenemos que ser conscientes de que dirigirnos a PDL1 por encima del 50% da solo un 45% de reducción del tumor y no un 70 o un 80%. Tenemos que ser conscientes de que para pacientes muy sintomáticos y quizá que nunca han fumado, el agente único quizá a veces no es suficiente y tenemos que utilizar una combinación. Como se puede ver aquí,
not close, is not like for the current and the former smokers where we have a huge benefit. And the other point is that maybe the females are another group where the combination is better than the single agent. We don't know if here there is an overlap with the never smokers, but I think that in your clinical practice, when you see a female never smokers, is generally not a very good responder to the immune checkpoint single agent. The other point is that we have other immune checkpoint inhibitors in the landscape of the first line. So maybe the question tomorrow will be not just to select immune checkpoint inhibitors alone, but if there is one better to the others, or we will select just based on the cost. The recent results of cemiplimab in the first line non-small cell lung cancer suggesting again that cemiplimab, which is an anti-PD-1 compound of another company, showed a very similar reduction of the risk of progression, which is 0.57. However, as you can see, the results are very preliminary, and we have to confirm this data with more results. However, what it is interesting from this trial is that this trial randomized also patients with some neglected populations, such as the HIV, the HCV, the HBV, and we saw that there is no additional toxicity if we add these categories to the single agent immunotherapy. But again, they confirmed what we saw before, so that the response rate is 33%, and it is not just, it is not 70%.
Y no es un 70% como los otros. Es 37% para pacientes con PDL1 por encima del 50%. Y una vez más, podemos ver las mujeres responden menos a la inmunoterapia y no presentaron resultados para los hábitos de tabaquismo. Estos son resultados publicados recientemente, hace un mes, de atezolizumab con quimioterapia. Aquí se puede ver la reducción en PDL1, considerando que había altos niveles de expresión y hay una reducción del riesgo del 30%. Pero se mostró que los que nunca habían formado y las mujeres se beneficiaban menos. Para esta población, quizá tengamos que decidir qué hacer, quizá agente único o combinación, y decidir si vamos a utilizar la combinación, si va a ser inmunoterapia o inmunoterapia quimioterapia. Y otro punto importante es la carga mutacional tumoral. La carga mutacional tumoral para agente único es lo que estoy mostrando aquí. También se presentan resultados para pembro como agente único, aunque el punto de corte no está claro. La carga mutacional tumoral potencialmente puede seleccionar la población que va a ser más sensible al agente único en comparación con los que tienen una expresión baja. Esto es donde se presentan los resultados.
Again, you can see that we are able to select a population more likely to benefit of the single agent compared to the chemotherapy. Moving to the combination, I think that we have to remember, as Jordi said before, that for the majority of the clinical trials, we have the initial part of the curves where we have a inversion of the curve, a crossing of the curve, suggesting that there is a population where the chemotherapy alone is superior to the immunotherapy alone. So this is why, after showing you all the results for the never smokers and also for the TM below and also for the females, it is important to develop also some combinations. Moving to the IO combinations, for reasons of time, I will go just through the nivolumab ipilimumab story, but just to remember that there was also the MYSTIC trial that was a totally negative trial for the combination. The Checkmate 227 was a very interesting trial in the beginning because they wanted to see a differential effect of Ipi/Nivo in PD-L1 positive and PD-L1 negative, but the trial was amended several times and it was enriched a lot, the population for PD-L1 more than 1%, and the trial became a trial with a two co-primary endpoint that was the progression-free survival in TMB high, considered with more than 10 mutation per megabase, and the overall survival in patients with PD-L1 expression. The primary endpoint of PFS for TMB was met, and we saw the results of the TMB in PD-L1 more than 1%. And as you can see, also this trial is a positive trial for PD-L1 more than 1%, and there are good things and bad things for this trial. The bad things are that there is again a crossing of the curves in the beginning for about 30% of the patients included in these clinical trials, but there is also a good news that because as you can see there is a sort of tail of the curves suggesting that after 3 years 33% of patients are alive at 1 year. But again, we don't know what is the contribute of PD-L1 more than 50% and what it is the contribute of the gray area of patients between 1 and 49%. The other unclear point is that what we are really adding ipilimumab to nivolumab, because if you look at the three curves simultaneously, you can see that the benefit of ipilimumab added to the benefit of nivolumab alone is present, but the magnitude of the benefit is not so high compared to the nivolumab alone. A very interesting results, in my opinion, although this was a secondary endpoint of the 227, but I think that it is a relevant finding, is that if you look at the patients with PD-L1 less than 1%, you can see 34% of patients alive at 3 years, which is, in my opinion, something very interesting, and it is worthy to be considered in the future research and also in the future of our clinic. I don't want to come back to what Jordi said before, but clearly we have to increase the outcomes also in PD-L1 more than 50% in the PD-L1 positive. TIGIT seems to be a very interesting endpoint, but if you split the patients PD-L1 more than 50% and patients in the gray area between 1 and 49%, the results are different, suggesting that maybe TIGIT is able to amplify the benefit of the immune checkpoint inhibitors, but again, the results are very preliminary, and and also the performance of atezolizumab in this trial was not so high, and we have to see something in the future. Moving to the combination of chemotherapy and immunotherapy, you can see that, again, maybe the chemotherapy is the only agent able to overcome the primary resistance to the immunotherapy, at least in a percentage of patients, because as we said every time, chemotherapy is able to induce the immunogenic cell death, but is able to enhance the activity of the T cell function. And on the other side, it is able to eliminate the immunosuppressive components such as the myeloid suppressor cells, the macrophages with M2 phenotype, and also the T regulatory cells. Based on this rationale, There are many trials. The most relevant are the Keynote 189, so the triplet with carbo or cis plus pemetrexed and pembrolizumab over the chemotherapy alone. When the trial was conceived, the crossover was allowed because the second lines were already present in the clinical practice of non-small cell lung cancer. And as you can see here, the main eligibility criteria were the performance status of 0 or 1. Brain metastases were allowed if they were asymptomatic, and the PD-L1 expression was not powered to see differences across the levels, but it was just a stratification factor for PD-L1 positive and PD-L1 negative. If we look at the results, and please bear in mind the results because we have to do the comparisons with the 9LA, you can see that the benefit at 2 years is 45%, the median overall survival is 22 months, and as you can see, unfortunately, it seems that there is no tail of the curves in the Keynote 189, but we must also say that the maturity of this trial is very high, and we have to compare the results also with the other trial with enough maturity. We have to remember that the benefit of the triplet goes across all the 3 subgroups, PD-L1 more than 1%, 50%, and also negative. And this is something very important because I see that in Italy, the people are trying to save the immunotherapy in the negative for the second part, and this is clearly a mistake because you see that the benefit in terms of overall survival for PD-L1 less than 1% is similar to the benefit that we have in patients with PD-L1 more than 50%. But what it is important is that with the chemotherapy, we are able to give a benefit also in patients, never smokers, and in the female where the benefit with the single agent is poor. Moving to another very important point is that, as I told you before in the beginning, the PD-L1 50% is not always active in terms of shrinkage of the disease. And so sometimes in patients with liver mets and in brain mets, starting with the immunotherapy single agent can be risky. And we have to remember that for patients with liver mets, the chemotherapy and immunotherapy is very active. And for brain mets, we have to remember that the median overall survival, although these data are on a handful of patients, is about 20 months, and we can consider this option for these patients also if they are very positive. Another very important point is that while it is possible that there is a role of TMB for the single agent, there is not a role of TMB for the combination with chemotherapy, because you can see here that both for TMB high and TMB low, the magnitude of the benefit is very similar in both the categories. Moving to the 9LA, I think that this trial is very important, although it is very early. It is a very pragmatic trial, 2 cycles of chemotherapy independent by the histology, and then a maintenance with the combination of Nivo-Ipi. The eligibility criteria of this trial were a stage 4. Also in this trial, EGFR and ALK alterations were not included. The primary endpoint of the trial was the overall survival, and the secondary endpoint of the trial were PFS, or overall response rate, and the efficacy by tumor PD-L1 expression that was a stratification factor. As you heard in the ASCO, Martin Reck presented in the virtual session the results, And interestingly, you can see that there is no crossing of the curves. The results are very early because the follow-up of this trial was very, very short. But again, the results are interesting. The median survival, the overall median survival was 15 months. There is no crossing of the curves, and it seems that there is a plateau. I can't say that this is my favorite trial, but I want to see the results in ASCO 2021 if I want to see if the tails will hold in the time. But again, it is interesting because, again, for the never smokers and the females, if you add chemotherapy, you gain more benefit than the single agent. I don't want to go back on the Pioneer trial because Jordi showed before the trial very well. But just going back to my initial part of my session, it is fundamental to do a correct sequencing of all what we have to go back to a precision medicine, both for the T cells and also for the tumor microenvironment, because at the time being, we have still a lot of questions pending, and we have to think that we are very far from a proper selection for the complexity of the microenvironment, but also the redundancy of the immune system. For example, what Jordi said before, for the adenosine is a very redundant system, and I'm not sure that targeting just one of the parts is enough. For PD-L1, more than 50%, a single agent could be enough, in my opinion, except for never smokers and also for patients with a very aggressive disease. For the women, maybe for patients with a low TMB, for patients with a low performance status, and there are many trials from the real world. There was no time to show you the results suggesting that for PS2, maybe the single agent is not enough. And remember that also here we have to improve our results. For PD-L1 less than 50%, I'm sure that we have to go with the combination, and the future research should address when using immunotherapy, chemotherapy, or chemotherapy and immunotherapy as a maintenance. So I would like to thank you for inviting me, and thank you for your kind invitation and for listening to my presentation.
Muchísimas gracias, Marina. Ha sido un placer.
Thank you very much, Marina. It has been a sheer pleasure. It has been the perfect ending. I'd like to congratulate the three speakers for their very high level and, for the questions that you're about to answer. No questions from the audience, so we're going to start a debate, Dr. Garcia Campello and myself. And the first question with regards to what Enrique and Jordi mentioned. Enrique, you talked about the nivolumab studies. If after 6 months you've got an answer, the probability for patients to evolve positively may lead us to think that this is a clinical option in order to understand who are the long-term survivors. And then you talked about the primary resistance after 3 months or 6 months. Therefore, can we think of those 3 months or 6 months in order to identify properly these patients? What is your opinion about this?
A ver, con los datos que hay ahora mismo,
with the existing information, if we want to identify those patients benefiting from immunotherapy, and the 6 months response can be a way of identifying them. However, we are still missing information in order to conclude that they are going to be LTS, survivors of over 5 years or more. the work published by nivolumab on second line of treatment carried out by with a PFS of 2 years, which will help us identify who are the long-term survivors. There is also a very relevant factor to take into consideration. These patients that respond well to IO and that can go well with IO, it's not if GR mutated. These are smokers with a lot of comorbidities and many other diseases. The decisions to be taken do not depend so much upon their oncological disease, but the other comorbidities they are suffering. We will have patients that are long-term survivors in IO, and their primary problem at the moment is their heart, their lungs, or other diseases more related to tobacco or age. 6 months is a bit short to decide if they're going to be long-term survivors. However, it can be a cutoff point in order to take decisions if a complication arises or anything that shall force us to act rapidly. Thank you. I agree with Enrique. We can somehow play importance to responses if they progress, if they do not progress after 6 months. This is somehow related. I'm worried about cases in which patients can progress after 6 months, a long-term survivor in the O study, or those patients that develop a toxicity and then we have to discontinue them. I do believe that defining who's going to be a long-term survivor, we will have to define these parameters in order to see what is the optimal treatment duration. Those patients that give answers after 3 months, partial responses are very limited. But if they have a partial response, do I have to continue the treatment for 2 years? Those completing 35 cycles of pembrolizumab, 80% of them were alive after 3 years, but perhaps with 1 year treatment, because they have received a positive response, we can go forward. As we know, there are no questions. The responses is the most important factor that can help us define the adequate duration of the treatment. Dr. Gracina has pointed this out. This is very important, not only because of the risk of toxicity, but the economic toxicity. We need to find these factors in order to define the optimal treatment duration. Thank you very much indeed. In line with the answers given on the capacity to predict all the information, who's a long-term survivor? I know all of you love liquid biopsy. There's a very interesting paper published by Cancer Research by Hellman. Those 12-month patients with no progression, the ctDNA. Well, perhaps, I'm not saying it is easy, do not misunderstand me, but perhaps the capacity to determine the ctDNA in such patients that reaches 2 months can help us define or decide who is a long-term survivor or to anticipate the progression. So what do you think of this? What are the limitations? I would like to understand your opinion about the capacity to help us identify long-term survivors. I think, shall I speak or Gracino wants to step in? Is that question open to everyone? Oh, go ahead, don't worry, Jordi. It's a wonderful job. We have to see this with patients with melanoma. So if they stop the treatment, we are quiet. But for us, it is very difficult to define the risk of the responses. Perhaps they have injuries, lung injuries that are not so visible. So if I have the patient with a circulating DNA negative, perhaps I can stop it. This is a valid strategy. Or if they are EFGR mutated, perhaps that really depends on the circulating DNA. We need other tools beyond the RESIS or immunoRESIS. We need more answers, and the biological answers are very important in these patients, and this can help us define time and response. But this is however, a very personal opinion. The liquid biopsy has a role. Marina, what are the limitations?
A space for research, for monitoring the response, not just on the liquid biopsy in terms of ctDNA, but maybe also the circulating immunophenotype can play a role, because there are also other immunocomponents, for example, such as the neutrophils or the Tregs that are able to predict the immunoresistance. So then I think that there are clearly technological issues, because what you can do in a research hospital, it can be clearly different than what you can do in a normal hospital. But I'm sure that maybe in the next future we will be able to add to the radiological response also a serological response, although we are very far from taking decisions from this aspect. But it's a very interesting research.
Yo creo que el trabajo es muy interesante y que, claro, el problema...
The work is very interesting. It is very important to try and identify the long-term survivors as soon as possible, because lung cancer patients with such diagnosis, they just want to discontinue any other treatment because of the complications of other comorbidities. And if we, remove that big burden that really prevents them from accessing other treatments, saying you're not going to survive over 2 years, I think this is very important. At the moment, there isn't any data that allows us, or a parameter that allows us to define this. And perhaps certain molecular parameters may be helpful to define these patients. Although we also know, based on the experience with patients with other alterations, the expression of a certain factor can disappear and reappear when we discontinue the treatment. The fact that certain markers may disappear from patients' blood, that does not necessarily mean this is going to disappear forever, or discontinuing the treatment. They can appear again. A lot of information is missing, and all these studies, analysis have to be included in a prospective fashion. Thank you very much indeed. In relation with this and with the entire problem we are suffering with the COVID-19 pandemic now, Marina has been one of the leaders of the terrible study. My feeling after having treated, we had 45 patients with positive lung cancer with positive COVID-19. Most of them that went poorly is because their tumoral disease was progressing, and probably those who had the disease control, even with immunotherapy, have been able to start after the infection. What you mentioned already is very interesting. These patients that may enter into ICU. Marina, what is your opinion about what we are living with the COVID-19? Immunotherapy protects, or perhaps at least patients with advanced cancer. What do you think? Is it controlled? The feeling is that the COVID-19 cannot, in principle, change them.
Results that TeraVolt presented, now there are in the database, there are more than 1,300 patients. So please fill the TeraVolt as much as you can, because so we can be more precise to have the evaluation. And we are trying also to do an homogram with an app to help the people to do the decision making. What it is very clear is that patients had a tumor before than 5 years, they have a mortality very similar to the normal population. Patients on immunotherapy and target therapy have less mortality compared to patients on chemotherapy. And patients with a progressive disease, they have more mortality compared to patients with a controlled disease. So what you said is super perfect from the data, from the TeraVolt perspective. I agree that also in my clinic in the beginning, if you remember, I was very scared about the immunotherapy because just for chance, 2 patients died in the beginning of the pandemic, but now we are much more relaxed with immunotherapy. Another very important point that we are analyzing in these days are the blood tests from the beginning. So, for example, we are doing the analysis now, but, and so please fill the data if you have the data. It is possible that, like the CC19 presented, the neutrophil lymphocyte inversion can play a role, the LDH can play a role, the platelets potentially can play a role. So maybe while the pandemic will continue, we will be more able to select. Another very important point that is important and is continuing to becoming positive in the TeraVolt is the use of steroids at the time of diagnosis, and also adjusted for the ECOG performance status. The presence of steroids at diagnosis is statistically significantly associated to the mortality. So, for example, in my clinic, we are trying to keep the patients as much as possible steroids free. Sometimes it's not possible, but it is possible that it is different to have steroids from the beginning and steroids during the COVID treatment, which is totally a different story.
Gracias, Marina. Muchísimas gracias y gracias por el esfuerzo que estáis haciendo con el TeraVolt. Yo creo que es
Thank you very much for the effort at TeraVolt. Thank you very much in this moment. I would like to talk about resistance and this complex world we are living. That has opened a lot of questions and uncertainties. Microbiome. Can we use and manipulate microbiome in reverting resistance? Do you think it is a strategy within this type of strategies that we are researching? I loved your reflection about Deltraxel. What the anti-angiogenic can contribute additionally in this context of lung cancer. We have very little time left, so if you can answer the questions quickly. I thought you were my friend, Charo. You asked about the microbiome and only mentioned it once. I think it is a very interesting strategy, an antibiogram. It is very interesting from the preclinical level, but we cannot manipulate it. A lot of patients with lung cancer that take a lot of antibiotics, the polypharmacy of more than 5 drugs is a negative factor for the efficiency of immunotherapy. So it'd be difficult to be able to control it. I'd like to, obviously. How long does it take us to modify microbiomes of these patients as they evolve? Do we have enough time for the entire microbiome to be replaced in a transplanted patient? When I was abroad, I took part in all the studies, and the theory is wonderful, but how do we apply this to practice? Is it sufficient to modify the microbiome to change the efficiency, or do I have to change the microbiome on all habits of patients? With regards to your second question, we must not forget the angiogenesis. This is a mechanism to revert resistance. In the Empower 150, there's clear evidence. And this year, the Japanese study was presented with a PFS of 16 months, which is an addictive effect. Any of these combinations, tetelizumab, nivolumab, or the cacanilimab, if the study is positive, is because of the efficiency or because the control group is suboptimal. We shall not allow these type of studies that are very costly from the toxicity point of view. These studies have been designed. There's more than 6 years than the angiogenic were designed. It's lowering the bar. It's like you want the trial to be positive. I don't think it's fair to us or the patients, knowing that the angiogenesis is a fundamental line of resistance to chemotherapy. I don't think it's fair. Thank you. We're running out of time. One final question to conclude this excellent roundtable. Do you think a patient who is a chronic patient in 5 years down the road is a patient that we can dream of as a healed patient in melanoma? What is your opinion about this?
I dream, yes. Dreams are free.
Exactly.
Yo creo que un paciente que está en respuesta a los 5 años es un largo superviviente, eso seguro.
They are long-term survivors after 5 years. Now, healing is a different concept. If they have done 2 years of Pembro, or with some toxicity, we have discontinued some of the other drugs and they still respond. We have to continue administering the drug in order to control the disease. And some patients are not going to be discontinued. I don't know if they are healed. That's a matter of concept, okay? They are long-term survivors. In practical ways, when taking decisions, these would be very similar. I think, well, staying healed is a long thing. Yeah, I think so. I'm heavily optimistic. So when you take a pill for cholesterol, all we have to do with these patients is to stimulate their immune system with a shot of anti-PD-L1 every 4 months. The average life of this is 26 days or twice yearly to re-stimulate your immune system. But we have to be optimistic and say, okay, because we see the light after the end of the tunnel, but there's a small percentage of them that do only require remember dosages, but I do not have any evidence thereof. Sorry. And with that message, we can conclude if you wish, Javier. Let's conclude with this positive message, right? It has been an excellent roundtable, excellent presentations. I see there are many possibilities, many options, but let's not bar. We have to continue researching and counting on professionals like you. Thank you very much indeed. Please remember that this session will continue, that we will be back at 3:30 sharp with a very important debate, the duration of the treatment with immunotherapy. It is a pleasure. We will continue after the break. Thank you very much for your cooperation. Thank you all.